Welcome to Disruptive Impulse Control and Conduct Disorders, Developmental and Diagnostic Perspectives. In this lecture, I'll be talking about a group of mental health conditions that involve difficulties with regulating emotions and behaviors. These challenges often lead to actions that break social norms or violate rights of others, creating significant problems in personal, social, and academic life, creating that key term that the DSM loves to use, clinically significant distress. I'll walk you through the developmental patterns, diagnostic criteria, and cultural factors related to these disorders, such as oppositional defiant disorder, conduct disorder, and intermittent explosive disorder. I'll also talk about how trauma, attachment, and brain functioning play a role in these behaviors. My goal is to help you understand not just the diagnostic labels, but also the human experiences behind them and how empathy and early intervention can make a difference. Disruptive impulse control and conduct disorders are a group of mental health conditions characterized by significant challenges in self-control of emotions and behaviors. These challenges often lead to actions that violate social norms, the rights of others, or both. What sets these disorders apart is their persistent nature. These behaviors aren't just occasional outbursts, but patterns that interfere with personal, social, or academic functioning. Examples include oppositional defiant disorder, where a child might frequently argue with authority figures or refuse to comply with rules. Intermittent explosive disorder, marked by sudden episodes of aggression like road rage or physical altercations. And conduct disorder, where more severe behaviors such as theft, physical cruelty, or destruction of property are common. Disorders like pyromania and kleptomania involve specific compulsive actions like setting fires or stealing, driven by tension and relief cycles. In pop culture, characters like Draco Malfoy in Harry Potter can sometimes reflect elements of ODD, with his defiance and hostility, though his behavior is often simplified as bad guy material. Similarly, Billy Hargrove from Stranger Things exhibits aggressive and impulsive behaviors that might align with traits of conduct disorder or intermittent explosive disorder, but these characters often lacked the nuanced portrayal needed to understand the root causes of these disorders. Unfortunately, media often portrays these disorders as synonymous with evil or inherently dangerous. Characters are frequently written as villains without exploration of the underlying psychological, environmental, or developmental factors contributing to their behavior. This can perpetuate stigma, suggesting that individuals with disruptive impulse control and conduct disorders are beyond help or destined to harm others. In reality, many individuals with these disorders respond well to intervention and support. Understanding disruptive impulse control and conduct disorders is crucial for two reasons. First, these disorders often manifest in childhood or adolescence, making early diagnosis intervention pivotal. By identifying these patterns early, counselors can implement strategies like behavioral therapy, family interventions, and school supports that can significantly alter a child's developmental trajectory. Second, practicing with empathy and unconditional positive regard is fundamental when working with individuals with disruptive impulse control and conduct disorders. Many clients with these disorders face societal rejection, misunderstanding, or even punitive responses rather than compassionate care. As clinicians, we must recognize that their behaviors often stem from unmet needs, past traumas, or neurological differences. Meeting these individuals with genuine empathy and acceptance creates a therapeutic environment where they feel safe to explore, heal, and grow. Finally, these disorders often intersect with environmental factors such as trauma, poverty, or family dynamics. Clinicians need to approach diagnosis and treatment holistically, considering these contexts rather than pathologizing behaviors without understanding their origins. This developmental lens helps reduce stigma and allows us to view these disorders as challenges to be managed, not labels that define somebody's character. By improving our understanding, practicing empathy, and fostering unconditional positive regard, we not only create pathways for individuals with these disorders to thrive, but also challenge the societal narratives that marginalize them. Disruptive impulse control and conduct disorders are primarily diagnosed in childhood or adolescence and are characterized by a failure to control behavior or emotions, leading to significant disruptions in functioning. Each disorder has distinct diagnostic criteria, and understanding these is essential for accurate diagnosis and treatment planning. So let's explore the core disorders in this category. Starting with oppositional defiant disorder, or ODD. ODD typically appears in children under the age of 12 and is characterized by a pattern of angry or irritable mood, argumentative or defiant behavior, and vindictiveness. According to the DSM-5 TR, symptoms must persist for at least 6 months and involve interactions with at least one individual who is not a sibling. Key diagnostic factors include anger or irritability, so that's frequent temper tantrums or easily annoyed demeanor. The second is argumentative or defiant behavior, so that's the persistent refusal to comply with authority, frequent arguments with adults, or deliberate attempts to annoy others. And again, this is not in regards to a sibling. It has to be a child or a person outside of the family unit. And lastly, vindictiveness, being spiteful or vindictive at least twice within the past 6 months. And we mean clinically significant distress level vindictiveness. This isn't just passive aggressive behavior. This is big stuff here. So ODD is often portrayed in media as bratty behavior, which trivializes the challenges faced by these children and their families. Understanding that these behaviors often stem from unmet emotional needs or family stressors is key. Intermittent Explosive Disorder, or IED, is characterized by recurrent episodes of extreme aggression that are disproportionate to the situation. These outbursts, which can include verbal aggression or physical attacks, occur without premeditation and cause significant distress. The DSM-5-TR sets an age criterion of at least 6 years for diagnosis. Key points include episodes of aggression, and these are often impulsive and not driven by external goals like financial gain. Frequency is considered, so outbursts may occur weekly for at least 3 months or result in physical injury or property damage 3 times within a 12-month period. And then there's something called emotional fallout. Individuals often feel guilt or regret following an outburst, distinguishing IED from other disorders, specifically conduct disorder. So we want to remember that guilt and regret in there. And this disorder is often sensationalized in media depictions of rageaholics or overly dramatic portrayals of people with uncontrollable anger, further perpetuating stigma. And next we have conduct disorder. Conduct disorder involves repetitive and persistent patterns of behavior that violates the rights of others or societal norms. Symptoms must be present for at least 12 months with at least one criterion in the past 6 months. Conduct disorder can be diagnosed in children or adolescents up to age 18. And again, key diagnostic factors include aggression towards people or animals. So that's physical cruelty, bullying, or intimidation. Destruction of property, it's deliberate vandalism or arson, it's not on accident. Deceitfulness or theft, persistent lying, stealing, or breaking into homes or vehicles. And serious violation of rules. So that might be truancy, running away, or staying out late before the age of 13. And I don't know why the DSM decides that 13 is the cutoff here, but they really want to make sure that we're aware that under age 13, if we have a child staying out late and doing all of these things, we want to look at them for conduct disorder. So a critical developmental point is that conduct disorder is a prerequisite for antisocial personality disorder in adulthood. While a person does not need a formal conduct disorder diagnosis, they must have met conduct disorder criteria during their childhood. This highlights the importance of early intervention to prevent the escalation of behaviors into adulthood. Pyromania involves deliberate and purposeful fire setting on more than one occasion. Key criteria include tension and relief cycle. So there's this buildup of tension before the act and a sense of gratification or relief afterwards. If you want to test out what that might feel like for yourself right now, try holding your breath. Build a lot of awareness around what it feels like to be holding onto your breath. There's a tension sort of building in your body. It wants to breathe. It's moving towards survival. And you might hold it for as long as you can. I don't know how long that might be, 30 seconds, 45 seconds. Maybe you can go over a minute. I can't ever go that far. I was never a really strong swimmer. But once you get to that absolute peak of you can't hold it anymore and you take a breath, you feel a relief afterwards. And so that's that tension and relief cycle that I'm talking about. It feels a lot like survival in the brain. And then we also want to look at motivation. So fire setting is not for personal, financial, or political gain, nor due to other mental disorders or substance use. So you might notice that in conduct disorder, there was fire setting as part of it. Pyromania really is the separate part of it. It's not the other elements of conduct disorder. It's really just the fire setting, and it has a lot of this tension and relief cycle in it. Pyromania is pretty rare and often dramatized in media, leading to misconceptions about its prevalence and underlying causes. Kleptomania is the recurrent failure to resist urges to steal items that are not needed for personal use or monetary value. And that's the key here, things that are not needed. Key diagnostic features include that tension and gratification cycle. So similar to pyromania, kleptomania involves that tension and relief cycle that feels a lot like survival. And then there's also a lack of motivation. The act is not motivated by anger, revenge, or psychosis, substance use disorders, anything else. Kleptomania is often misunderstood as mere shoplifting, but it is driven by an internal compulsion rather than external factors like financial need. And this is where I might argue something about pyromania and kleptomania might fit more underneath the anxiety or OCD chapter of the DSM rather than under this impulse control one. But that's just me. The DSM-5-TR emphasizes symptom clusters. So we have ODD with anger, irritability, defiant behavior, and vindictiveness, conduct disorder with repetitive aggression, deceitfulness, and rule breaking. There's behavioral patterns like stealing and fire setting in kleptomania and pyromania, respectively. And there's also age and developmental expectations. ODD is diagnosed in younger children, while conduct disorder includes adolescents. Intermittent explosive disorder requires a developmental understanding, ensuring episodes are not age appropriate tantrums. And within all of this, we also want to look at age appropriateness of any of the behaviors. Tantrums are age appropriate. I'm sorry to break it to you. Kids have bad days and they don't always have the best way to express their feelings. So a tantrum is going to happen. Sometimes hitting, kicking, slapping might also happen. So we really want to look at age appropriateness here. By understanding the nuanced diagnostic criteria and developmental context of these disorders, counselors can better identify and support effective individuals. Early empathetic interventions rooted in unconditional positive regard are critical in preventing long-term consequences like antisocial personality disorder or further societal marginalization. Addressing media misrepresentations can also help combat stigma and promote accurate understanding in public contexts. Onset and development of disruptive impulse control and conduct disorders. So, understanding the etiology and development of disruptive impulse control and conduct disorders requires an exploration of trauma, developmental psychology, neurobiology, and environmental factors. And this section integrates Erikson's psychosocial stages, Maslow's hierarchy of needs, and recent research to provide a comprehensive view of why these disorders develop and how they progress over time. So, starting with some early indicators in childhood development. Disruptive impulse control and conduct disorders often emerge in childhood or early adolescence with symptoms such as defiance, aggression, or destructive behavior acting as early red flags. These behaviors can be traced back to developmental and environmental disruptions. First, we want to talk about trauma and early experiences. Children exposed to adverse childhood experiences or ACEs, such as abuse, neglect, or household dysfunction, are significantly more likely to develop behavioral disorders. Trauma can disrupt the formation of secure attachments, leading to difficulties in emotional regulation and trust. Erikson's first stage, trust versus mistrust, is foundational. If a child does not develop a sense of trust in caregivers during infancy, they may carry mistrust into later stages, which can manifest as defiance or aggression in disorders like oppositional defiant disorder. And when looking at Maslow's hierarchy of needs, unmet basic needs like safety and belonging can exacerbate behavioral issues. A child growing up in an unsafe or unpredictable environment may act out as a maladaptive way of seeking stability or attention from their caregivers. And then we also want to look at the neurodevelopmental factors. Children with neurological differences such as atypical prefrontal cortex development or dysregulated amygdala activity may struggle with impulse control and emotional regulation. Neurotransmitter imbalances, particularly involving dopamine and serotonin, are linked to impulsive behaviors. For example, dopamine dysregulation can heighten reward-seeking behaviors, while serotonin deficiencies may contribute to aggression. So looking at how developmental stages influence symptom expression. Behavioral symptoms often align with developmental milestones and stressors. In early childhood, so like 3 to 7 years, defiance and tantrums may emerge in ODD. Children begin testing boundaries. In middle childhood, so 8 to 12 years, symptoms of conduct disorders such as aggression, deceitfulness may surface as peer influence grows and rule-breaking behaviors escalate. When we're looking at adolescence, so 13 to 18 years, more severe symptoms like criminal activity or substance use may appear, particularly in the presence of unresolved trauma or untreated earlier symptoms. Without intervention, the progression from ODD to conduct disorder to eventually antisocial personality disorder is a concerning trajectory. The DSM-5-TR highlights that antisocial personality disorder requires evidence of conduct disorder symptoms before age 15, even if the individual was not formally diagnosed. This highlights the importance of identifying and addressing these behaviors early. And when looking at the recent research in etiology, where recent studies have deepened our understanding why these disorders develop, we want to consider trauma and stress. A 2023 meta-analysis in trauma, violence, and abuse found that children with higher ACE scores are up to 4 times more likely to develop behavioral disorders, highlighting the critical role of early intervention in mitigating this risk. We also want to look at genetic and epigenetic factors. Research in Neurobiology of Stress in 2022 suggests that genetic predispositions to impulsivity or aggression can be exacerbated by environmental stressors, altering the child's neurodevelopment through epigenetic mechanisms. Look at parenting styles. A 2023 study in Journal of Child Psychology and Psychiatry showed that authoritarian or inconsistent parenting increases the likelihood of defiant and aggressive behaviors, while authoritative parenting acts as a protective factor. And we're not here to blame the parents. All we're doing is looking at research that shows different types of parenting styles, what might be happening in the genetics and epigenetics, and history of trauma and stress. There can be a million other reasons why these things develop. The most important thing is to recognize the signs early and get early intervention. We can also look at neurobiology and pharmacological considerations. Neurobiological research sheds light on how brain function contributes to these disorders and informs potential pharmacological treatments. When we're looking at the brain structures, the prefrontal cortex, responsible for impulse control and decision making, often shows reduced activity in children with conduct disorder and intermittent explosive disorder. The amygdala, associated with emotional responses, may be hyperactive, leading to exaggerated reactions to perceived threats. We also see that in survivors of trauma and abuse. When looking at the neurotransmitters, dopamine is at play, central to reward-seeking behavior. Its dysregulation may drive impulsivity. Serotonin deficiencies are linked to aggression and mood instability. And then we have GABA, which plays a role in inhibitory control. Deficits can exacerbate impulsivity. So this all leads us to talking about what medications might work here. So stimulants often used for co-occurring ADHD can improve focus, but have side effects like appetite suppression or insomnia. There can be mood stabilizers, effective for reducing aggression and intermittent explosive disorder, though potential side effects can include weight gain and sedation. Then we have the SSRIs, selective serotonin reuptake inhibitors. So that can help with emotional dysregulation, but may cause nausea or restlessness. And then finally, we have antipsychotics. So they'll occasionally be prescribed for severe aggression or conduct disorder, but carry risks like weight gain or metabolic syndrome. While counselors do not prescribe, understanding these medications is crucial for coordinating care and addressing client concerns about side effects or efficacy. No medication is going to change behavior. Medications are there just to create the time and the space so that the kiddo is available to use the coping skills necessary that they're learning in therapy. Intervening early is critical to bringing the progression from oppositional defiant disorder to conduct disorder and potentially antisocial personality disorder. Effective interventions include trauma-informed care, addressing underlying ACEs through therapeutic approaches like cognitive behavioral therapy or trauma-focused CBT. There's parent training programs, which teaches parents consistent supportive techniques to manage behavior effectively, and school-based supports promoting social emotional learning to build skills like empathy and self-regulation. The onset and development of disruptive impulse control and conduct disorders are influenced by a complex interplay of trauma, developmental factors, neurobiology, and environmental stressors. You can consider it like the perfect storm. By understanding these underlying causes and recognizing the signs early, clinicians can implement strategies that promote healing and resilience, ultimately reducing the risk of lifelong challenges. Practicing with empathy and knowledge of pharmacological options when relevant helps ensure comprehensive care that addresses both the individual's symptoms and their roots. So we're going to look at differential diagnosis and comorbidities. So understanding how to distinguish disruptive impulse control and conduct disorders from other mental health conditions and recognize common comorbidities is crucial for accurate diagnosis and effective treatment. These disorders often coexist with other conditions, and their symptoms can overlap or mask each other, requiring careful clinical assessment. So let's dive into a more detailed example to illustrate these complexities. So just an example, I once worked with a client in addiction recovery, and we'll just call her Sarah. And Sarah had been using heroin for several years, and during her addiction, she frequently stole small items from stores: snacks, batteries, toiletries, things that she didn't need for survival, but could easily resell or trade to support her drug habit. On the surface, her behavior seemed to fit the criteria for kleptomania, reoccurrent stealing without clear personal or financial necessity. Sarah even described feeling a sense of relief after taking the items, followed by guilt. However, the underlying motivation for her behavior was critical in understanding her diagnosis. Kleptomania is defined by a pervasive compulsion to steal, driven by internal urges and unrelated to external goals like financial need or substance use. For Sarah, her stealing was tied directly to her heroin addiction. It served as a means to obtain money for drugs. When she entered recovery and achieved sobriety, her stealing stopped entirely, and this was a clear indicator that her behavior was not kleptomania, but rather a symptom of her substance use disorder. The distinction is important because treating Sarah for kleptomania rather than focusing on her addiction would have been ineffective. It's a reminder that understanding the context and motivation behind behaviors is just as important as identifying the behaviors themselves. So, starting with differentiating from similar disorders, let's start with ADHD. So this is impulsivity and rule-breaking behaviors seen in disruptive impulse control and conduct disorders can resemble ADHD. However, ADHD behaviors often stem from poor attention and impulse regulation rather than defiance or aggression. So a child with ADHD might interrupt a teacher repeatedly because they struggle with self-control, whereas a child with oppositional defiant disorder might refuse to follow a teacher's directions out of defiance. And then moving on to autism spectrum disorder, social difficulties and rigid behaviors in autism may be misinterpreted as oppositional or aggressive. However, these behaviors typically arise from challenges in social communication or sensory processing, not an intent to defy or harm others. And in mood disorders, emotional outbursts in bipolar disorder or major depressive disorder can mimic the anger and irritability seen in oppositional defiant disorder or intermittent explosive disorder. The episodic nature of mood disorders, however, distinguishes them from the pervasive and situational behaviors in disruptive impulse control and conduct disorders. And then looking at comorbidities, we want to consider substance use disorders, mood and anxiety disorders, and neurodevelopmental disorders. So, like Sarah's case, substance use frequently co-occurs with disruptive impulse control and conduct disorders, particularly conduct disorder. Substance use can amplify impulsivity and aggression, creating a cycle of escalating behaviors. Depression and anxiety often co-occur with disorders like oppositional defiant disorder, exacerbating symptoms of irritability and defiance. In adolescence, untreated anxiety can fuel oppositional behaviors as a defense mechanism against overwhelming fear or stress. ADHD and learning disorders commonly co-occur with disruptive impulse control and conduct disorders, particularly in children with oppositional defiant disorder or conduct disorder. And these comorbidities complicate emotional regulation and social interactions, amplifying disruptive behaviors. Disruptive impulse control and conduct disorders often travel with comorbid conditions, either intensifying the primary symptoms or masking the underlying disorder. So, for example, a child with ADHD and ODD may experience heightened frustration due to difficulties in task completion, which leads to increased defiance. And previously, I've heard the rule that when a child is presenting with ODD, because the rate of comorbidity is so high with ADHD, clinicians should be treating any child with ODD as if they also have ADHD. And then if we're going to talk about masking, an example might be an adolescent with conduct disorder who might engage in aggressive behavior to hide underlying depression, making the depression harder to identify. So by understanding these complexities, counselors can differentiate behaviors that are symptoms of a disorder from those influenced by external factors, leading to more effective and compassionate treatment plans. Disruptive impulse control and conduct disorders do not exist in isolation from cultural influences. Rates of these disorders and their expression can vary significantly across countries and communities due to cultural, societal, and environmental factors. Understanding these differences is crucial for accurate diagnosis and effective treatment. In the United States, disruptive impulse control and conduct disorders are diagnosed at higher rates compared to many other countries. For example, the prevalence of oppositional defiant disorder and conduct disorder in the United States children ranges between 2 to 16%, influenced by factors like socioeconomic disparities, access to healthcare, and community violence. Cross-cultural studies suggest lower rates of these disorders in countries with strong social cohesion and collective parenting models such as Japan or Scandinavian countries. In these cultures, behaviors that might be seen as disruptive in the United States could be addressed through community-based interventions before escalating to clinical attention. In low and middle-income countries, rates are less studied, but may be underreported due to limited access to healthcare services and differing cultural perceptions of disruptive behaviors. It's important to remember that behaviors that constitute a disorder in one culture may be perceived differently in another. When looking at defiance and aggression, in individualistic cultures like the United States, defiance may stand out more because it clashes with expectations for self-regulation and independence. In contrast, collectivist cultures may interpret such behaviors within the context of family dynamics or group harmony. Looking at authority and social structure, societies with strict hierarchical structures may label defiant behaviors as pathological more quickly than those with flexible or egalitarian models. And then we also have stigma in seeking help. In some countries, behaviors associated with disruptive impulse control and conduct disorders might be attributed to moral failings or spiritual causes rather than psychological ones, leading to delayed or avoided treatment. And rates of these disorders are also linked to environmental stressors, which vary globally. So talking about the socioeconomic disparities, in the US, children in low-income households experience higher rates of conduct disorder and oppositional defiant disorder, likely due to stressors like poverty, exposure to violence, and inconsistent access to education and healthcare. And we also want to consider immigration and acculturation stress. Immigrant families often face unique challenges, including adapting to new societal norms and facing discrimination. These stressors can exacerbate behaviors that resemble disruptive disorders, requiring careful cultural competence in diagnosis. And counselors must consider cultural context when diagnosing and treating these disorders. So we want to avoid over-pathologizing. Behavior should be evaluated against cultural norms to avoid mislabeling normative behaviors as disordered. If there is a cultural reason for behavior, then it is not a disorder. We want to use culturally adapted interventions, Treatment plans should respect cultural values and incorporate community or family-based approaches when appropriate. We also want to consider global learning. Drawing from successful interventions in other countries, such as community parenting models in Scandinavian countries, can inform more holistic approaches in the United States. By addressing cultural differences, clinicians can improve the accuracy of diagnoses, enhance client engagement, and reduce the stigma associated with disruptive impulse control and conduct disorders. And this culturally informed perspective fosters more equitable and effective mental health care across diverse populations. When examining disruptive impulse control and conduct disorders through the frameworks of the DSM-5TR and the ICD-11, notable similarities and differences emerge. Both systems aim to classify and guide the diagnosis of these disorders, but they reflect distinct philosophical and cultural underpinnings that influence how behaviors are understood and treated. So starting with the similarities between the DSM and the ICD. So core diagnoses, both DSM and ICD include key disorders such as ODD, CD, and IED. Pyromania and Kleptomania are also recognized in both systems as distinct conditions. Both systems require that behaviors cause significant distress or impairment on social, educational, or occupational functioning. Both frameworks emphasize the importance of developmental appropriateness, noting that behaviors must exceed what is typical for the individual's age and cultural background. Some of the key differences between the DSM and the ICD are the terminology and framework. The DSM uses detailed symptom-based criteria and emphasizes behavioral patterns over time. It often ties diagnoses to developmental trajectories, such as the progression from conduct disorder to antisocial personality disorder. The ICD-11 organizes these disorders under disruptive behavioral and dissocial disorders, emphasizing a dimensional approach that considers severity and context rather than strict symptom thresholds. This allows for more flexibility in diagnosis, particularly in non-Western contexts. Regarding cultural sensitivity, the ICD-11 explicitly integrates cultural considerations, providing guidance on how behaviors may vary across cultural contexts. For instance, the symptom avoids pathologizing behaviors that might be seen as normative in specific communities. The DSM-5TR includes cultural considerations but tends to focus on universal criteria, which can sometimes overlook cultural nuances. And then finally, the focus on etiology and context. The ICD-11 emphasizes the influence of environmental and social factors, aligning more closely with non-pathologizing lenses like attachment theory or systems theory. For example, conduct disorder may be described in terms of relational patterns or family dynamics rather than solely as a set of problematic behaviors. The DSM-5TR focuses more on symptom clusters and behavioral patterns, which can sometimes pathologize behaviors without fully exploring their relational or contextual roots. Using alternative frameworks like Gestalt therapy and attachment theory provides a more holistic understanding of these disorders, moving beyond the pathologizing perspective of diagnostic manuals. Gestalt therapy views behaviors associated with disruptive impulse control and conduct disorders as attempts to meet unmet needs or express unresolved emotions. So, for example, a child with ODD might be seen as expressing a need for autonomy or validation in an environment where they feel powerless. A teen with conduct disorder may be responding to feelings of disconnection or alienation within their family or community. The emphasis is on understanding the whole person in their environment rather than isolating their behaviors as problems to be fixed. And looking from attachment theory, disruptive behaviors can often be traced back to insecure attachment patterns formed in early childhood. So, for instance, a child with intermittent explosive disorder might exhibit explosive anger as a way to test the safety and responsiveness of caregivers. Conduct disorder behaviors such as deceit or aggression may develop as adaptive strategies in environments where secure relationships are lacking. Treatment from this perspective focuses on building trust, repairing attachment wounds, and creating consistent, nurturing relationships. So some practical implications for clinicians. Understanding cultural variability. The ICD-11's broader emphasis on cultural context can help clinicians avoid over-pathologizing behaviors that are normative in the client's cultural background. For example, defiance in a collectivist culture might reflect efforts to assert individual needs within a group-focused system rather than being inherently oppositional. Using Gestalt or attachment-informed approaches can complement diagnostic systems, helping clinicians understand the underlying motivations for behavior. A diagnosis like conduct disorder could be reframed as a child's adaptive response to trauma, guiding treatment towards relational repair rather than punitive measures. And while counselors do not prescribe, understanding the DSM and ICD classifications and how they intersect with medication use is critical for interdisciplinary collaboration. For example, when working with a child diagnosed with oppositional defiant disorder who is prescribed an SSRI for comorbid anxiety, the counselor can monitor behavioral changes and help the family navigate potential side effects such as increased agitation. When the DSM-5-TR and ICD-11 share foundational elements in their classification of disruptive, impulse control, and conduct disorders, the ICD-11's flexibility and cultural sensitivity allows for more individualized and contextualized approaches. Integrating these diagnostic frameworks with non-pathologizing perspectives like Gestalt or attachment theories further enriches our understanding and treatment of these behaviors. This holistic view encourages empathy, reduces stigma, and prioritizes relational healing over symptom management. Disruptive impulse control and conduct disorders are a group of mental health conditions characterized by persistent patterns of defiant, aggressive, or rule-breaking behavior. These disorders often emerge in childhood or adolescence, and their severity can vary widely from mild defiance to serious violations of societal norms. So, reviewing the behavioral patterns and developmental trajectories. Oppositional defiant disorder often manifests as frequent arguments, defiance, and irritability in younger children. Conduct disorder involves more severe behaviors such as aggression or property destruction and is a prerequisite for later diagnoses of antisocial personality disorder. Intermittent explosive disorder is marked by impulsive, aggressive outbursts disproportionate to the situation. Pyromania and Kleptomania are specific impulse control disorders defined by cycles of tension and relief, but are rare and distinct. Cultural norms influence the interpretation and diagnosis of these behaviors. What is considered disruptive in one culture might be normative in another. The ICD-11's dimensional and culturally sensitive approach offers flexibility in understanding these disorders within their social and environmental contexts. And when looking at cause and contributing factors, we want to look at trauma, developmental influences like attachment disruptions, parenting styles, unmet needs like in Maslow's hierarchy. And we also want to look at neurobiology, so impaired prefrontal cortex activity, amygdala dysregulation, and neurotransmitter imbalances, specifically dopamine and serotonin, can contribute to behavioral and emotional dysregulation. Common comorbidities include substance use disorders, ADHD, or mood and anxiety disorders. These conditions can mask or exacerbate symptoms, complicating diagnosis and treatment. Distinguishing these disorders from ADHD, autism spectrum disorder, and mood disorders is crucial. For example, impulsivity in ADHD is unintentional, while in conduct disorder, it may be intentional and goal-driven. And moving to treatment and clinical considerations, we want to take a non-pathologizing approach. So Gestalt therapy and attachment theory might offer some valuable perspectives, reframing behaviors as adaptive responses to environmental stressors or unmet needs rather than inherent flaws. Emphasizing relational repair and trust building can reduce behavioral symptoms over time. We want to look at early intervention. So early identification and support can disrupt the trajectory from ODD to CD and potentially antisocial personality disorder. Evidence-based treatments like behavioral therapy, parent training like parent-child interaction therapy, and school-based interventions can be critical. Addressing systemic issues such as poverty, family conflict, and community violence is vital. A holistic systemic approach can help clients and their families navigate challenges that contribute to behavioral disorders. And some additional things to consider is the role of stigma. So media portrayals often villainize individuals with these disorders, reinforcing the stigma. Clinicians must advocate for understanding and emphasize the importance of contextualizing behaviors with each individual's life story. Building a strong support system for families is as important as addressing the individual's behaviors. Family therapy and community resources can mitigate environmental stressors. And while these disorders are often diagnosed in childhood, behaviors can improve with time and intervention. Emphasizing that attachment patterns, behaviors, and even brain functioning can change reduces hopelessness for clients and families. Disruptive impulse control and conduct disorders present complex challenges, but also opportunities for meaningful intervention. By integrating diagnostic frameworks, cultural sensitivity, and holistic therapeutic approaches, clinicians can support clients in navigating these behaviors, fostering growth, and building healthier relationships. And this next slide and final slide is just some additional resources. So if you're interested in learning anything more about what I talked about today, I'd highly recommend checking out these resources. A lot of them are books and articles that I talked about in the lecture today, but they might paint a better picture of a non-pathologizing approach to treating and understanding these disorders. Thanks. Please reach out if you have any questions.